12 sharp we get going.
Okay.
And most of the talks are pre-recorded, barring one or two.
Okay.
And we'll have a discussion which is going to be live towards the end.
So tell me, the Tamil Nadu EP meeting is being held every year?
Yes, sir, we are supposed to, but last year and because of the pandemic, we could not have a in-person meet.
Right.
This is the 6th edition, and this is conducted under the aegis of CSI Chennai chapter. And you see Dr. Swaminathan, sir, he is the head of Department of Cardiology of Madras Medical College. And the CSI Chennai is located in the premises of the Department of Cardiology in MMC. And last year we conducted the NIC through that through the Madras Medical College, and sir has been one of the front runners in academic programs in the state.
It's the MMC, which is the second oldest medical college in India? Is that the?
Yes.
I think Kolkata. I think I had gone to Kolkata Medical College where they said that started, and the next day the MMC, and I think the next was the Goa Medical College, was the Portuguese one.
Yeah, more than 185 years old.
Okay. And so Chennai traditionally used to have 4 government colleges, right? One was MMC, and then Loyola. Loyola is another one?
No, Loyola is an art college, sir. It is not a medical college.
Kilpatrick and Stanley.
Okay. So three medical colleges were traditionally there.
Yes, sir.
So sorry to interrupt. I think the event managers want us to get cracking. So with a small word of introduction, good morning to all of you. At the outset, I would like to invite you all on behalf of the organizing committee of Tamil Nadu EP Interventional Council, the 6th edition, which conducts the program under the aegis of CSI Chennai chapter. My good friend and senior Dr. Swaminathan sir is there. Good morning, sir. Professor Yash sir, good morning. And my good friend and colleague Guru is there with me. Good morning. The conference, albeit virtual, has attracted around 470 registrations across India, Africa, Southeast Asia, as far as Fiji. And 4 credit points have been sanctioned by the Tamil Nadu Medical Council for the same. This goes to show the enormous impact of electrophysiology in clinical practice. The 2-day deliberations will cover a wide range of topics, simple to complex. And our 2 international speakers and guests, Drs. Dheeraj Gupta and Dr. Archana Rao, are renowned in their areas of work the world over. The array of national speakers and chairpersons, as you can see on the screen at the moment, are well accomplished in the field of EP in our country, and everybody knows Dr. Yash sir, Dr. Narayan and Dr. Swaminathan sir, not only in our country, across Southeast Asia and across the world. I am sure the 1.5-day program will be an academic feast for all of us, and we'll get wiser by the end of the conference. Please feel free to post your queries in the chat box, and I'm sure the chairpersons will be more than happy to sort it out, because we are sort of cramped for time and we'll have very little time for discussion. I would like to once again invite you all to join and get started with the proceedings. Hopefully, God willing, we all meet in person for the next year's edition. Thank you very much. And over to Dr. Yash sir to conduct the first session. Thank you, sir.
Thank you, Dr. Jai Shankar. It's indeed a pleasure, and we are actually impressed that the Tamil Nadu, your association has been holding these. This is the 6th edition. We can't say the same actually in Mumbai and Maharashtra. So we're looking forward to this first session, and the topics also seem to be of quite interest. And can we ask the first speaker to start the talk? Cardiac anatomy.
It's all recorded and it will start playing, sir.
Okay.
Thank you. Thank you.
Hello, good morning, everyone. I thank you for the opportunity for this first lecture of TNEPIC. So cardiac anatomy is very important for an electrophysiologist. So this is what is known as Valentine heart orientation. Actually, this is not exactly what you see when patient is on table in the cath lab. So the exact orientation of the heart lies like this. So these are the volumetric reconstructions of cardiac MRI images. The when the patient lies on table or when the patient stands in front of you, so the right ventricle is anterior, right atrium is right, left atrium is posterior, and left ventricle is towards left. In exact anteroposterior view, left ventricle you see only the apex. So this is the Arebo position, what I describe it as resting position, which separates clearly the ventricles from the atria, and Elebo position gives clearly the right and left chambers, especially the right ventricle and left ventricle, which gives the exact orientation of interventricular septum. And this is what I describe it as the attention position of Elebo view and resting position of Arebo view. So before going towards exact anatomy, so these are the layers of the heart known as the pericardium, consisting of both visceral and parietal. They're very important for an electrophysiologist during ablation, and for two reasons. Because while ablating, we may develop pericardial tamponade, very important, and cardiac emergency, so requiring pericardial synthesis. And for epicardial ablation, for the refractory arrhythmias, especially ventricular epicardial arrhythmias. And two nerves that are very important to realize their anatomy is both right and left phrenic nerve. And right phrenic nerve, which is very close to both superior vena cava and right superior pulmonary vein of the left atrium. So you can see histologically how close the right superior pulmonary vein is towards the right phrenic nerve. Very important while ablating atrial tachycardias and of SVC or RSPV origin, including while ablating, especially atrial fibrillation. So left phrenic nerve is important when we consider ablating near the area of left atrial appendage, and also while inserting the LV lead of the CRT device. So this is the exact right atrial anatomy. At the base of SVC in right atrial appendage lies the sinus node, and which is the pacemaker of the heart. This exact anatomy, people describe it as the tadpole shape. This is like basmati size rice, basmati rice grain size, and internally it corresponds to the uppermost portion of the crista terminalis. So the tail end can traverse up to the opening of IVC or up to the even coronary sinus os, which has distinct histological morphology with central arteriole of the right coronary artery, the synodal artery, surrounded by typical distinctly morphological nodal cells, which are clearly apart from the atrial myocardium, and it can traverse along the crista terminalis. So the crista terminalis ends as the eustachian ridge and the tendon of Todaro along the ridge, so which we are going to come very soon. And intraatrial septum is very important for the septal puncture, and puncture through the especially fossa ovalis. We should be aware that inadvertent punctures can result in complications, especially the inclined nature of the left superior pulmonary vein. If you just advance the needle very straight, you may even puncture the roof of the left superior pulmonary vein, resulting in tamponade. So you should be aware of the variations of fossa ovalis, which can be thin and which can be thick with muscular rims like this, which may be difficult to penetrate. And it is always puncture the true fossa ovalis to reach the left atrium for arrhythmias, flutter ablations, and even sometimes LV ablations. And this is important anatomical landmark, that is Waterston sulcus, where usually surgeons will access the left side of the heart after incising this. Sometimes inadvertently posterior puncture of the septum can result in tamponade, especially after removing the sheath. So this is exactly the lower portion of the intraatrial septum. So intraatrial septum anteriormost portion, lower portion, consists of the penetrating bundle, and the mid portion of the interatrial septum consists of the AV node, and the lateral portion starts with coronary sinus opening and cavotricuspid isthmus, and then the opening of the coronary sinus. This is the enlarged view of the coronary sinus guarded by the Thebesian wall with fluoroscopic correlation. And very important for two reasons, that is slow pathway ablation of AV and RT, as well as cavotricuspid isthmus ablations of flutter, both typical and atypical. So especially the triangle of Koch and triangle of Cosio. So both are important for AV and RT and flutter ablations. So this is important, especially from the base of the CS to the septal tricuspid lifted, where there will be slow pathway approaches where we ablate for the AV and RT, typical slow fast AV and RT ablation. And this cavotricuspid isthmus is very important for flutter ablations. So its anatomical variations are very important. So there'll be a distinct length where it may be smooth, rough, or with pouch, and it may be with a lot of pectinate muscles, a lot of rugosity. This is a beautiful paper from Poland consisting of nearly 200 cadavers. So beautifully depicting the cavotricuspid junctions, which can be smooth like this, combined, or total pectinate infiltrations. And there may be pouches at times where we need large and 8 mm tip for ablations. So this is typical flutter circuit, clock, both counterclock, and where we demonstrate bidirectional blocks. And we should also be aware of the anatomical variations of the coronary sinus, which can be totally devoid of the valve, which may have valve sometimes, which will be very large valve, difficult to access through femoral approach, where eventually needs jugular venous approach, and sometimes there may be fibrous strands just guarding the valve. And GRE malformations, where the catheters can entrap, especially while accessing for salvovalgus and CS cannulation. And left atrium is important. So especially the posterior venous portion is very important, which consists of the 4 pulmonary veins. Both left atrium and pulmonary veins are the source of atrial tachycardias and flutters and fibrillations. We all know that, especially after the landmark publication by Hisagiri group, demonstrating that muscular sleeves can extend into the pulmonary veins. That can result in the most common cause of non-valvular atrial fibrillation. This is one such patient. As soon as I inserted the catheter in the pulmonary vein of chronic atrial fibrillation, you see the rapid chaotic irregular rhythm, and definitely, we know the anatomy, especially the 4 distinct ostia versus common ostium, and what are the numbers of pulmonary veins, very important before we ablate the left atrium. And it is better to know the neighborhood to avoid collateral damage, especially the esophageal perforation while ablating the left atrium, because the most portion of the left atrium is very close to esophagus, just 1 to 2 millimeters depth. So intra-atrial connections are important, especially that can transmit the electrical impulses from sinus node. Most important and distinct anatomic entity is Bachmann's bundle, and there may be some other smaller muscular connections just above and below the right superior and inferior pulmonary veins. And this is the AV node junctional area. So the mid portion of the lower septum, intra-atrial septum with AV node, and anterior portion penetrating bundle, his bundle with the distinct right bundle, left bundle, right bundle, which is a sheathed one. So it is important to know that while ablating the slow pathway AV and RT, to avoid inadvertent damage of the AV nodal artery, because it is very close, that can result in heart block. So the original Tavares description of the penetrating, AV node compact and penetrating portions of the AV node even holds very well today. So consisting of the conduction system, and this is the thinnest portion of the interventricular septum, that is membranous septum, where there will be penetrating portion of the AV node. These are the accessory pathways which are distinct myocytes, which are embryological remnant connecting both atria and ventricle, sometimes even from the AV node to the crest of the muscular septum, consisting of nodoventricular accessory pathways. So after the penetrating bundle, the bundle branches, right bundle, which is a sheathed one, can traverse along the moderator band, reaching the free wall of the right ventricle, and left bundle is like a broomstick. And immediately after reaching the left ventricle, it divides into fascicles, anterior and posterior, and which ends up, both the bundle branches ends up in distinct cellular network known as the Purkinje cells, which are distinct cells standing apart from ventricular myocytes, where they conduct electrical impulses to the direct myocytes. This is the normal anatomy of the right ventricle. So inflow and outflow. Between inflow and outflow, you have a smooth infundibular portion, sometimes which can consist of septomarginal trabeculations. Especially these outflows are very important for triggered ectopic activity. So in structurally normal heart. So these are the outflow tract portions where they are the sites of ectopic activities. So the right ventricles is the most commonly accessed chamber for any electrophysiological study, and both the outflow tracts of the ventricles, they cross each other. So right ventricle outflow tract goes to left, and left ventricle outflow tract comes to right. So being the pulmonary trunk lying anterior. This is just to show that so outflow tract of the right ventricle is very close to the main trunks, the both, especially left main. Very, very important when we are ablating the outflow tract VTs from the right side, especially posterior septal, posteriorly towards the septum. So this is just to show that how close to the pulmonary infundibulum these main pulmonary trunks are. So because the cusps are fibrous structures, why should we develop arrhythmias? Why should we ablate inside the cusps? Though medially, that is towards luminal, the cusp is attached to the annulus. This is actualus, basal attachment, whereas the myocardial sleeves epicardially extends beyond the cusp and ventricular junction. So that is why we name it as the cuspal origin of arrhythmias, and that can be easy way to access through the ablation catheter to reach up to here, because the source can be this portion of the myocardium where that can be accessible and can be ablatable. So so this is what we saw now from the junction. So medial side it may looks like a cusp, but when you see inner side, that is epicardial side, actually myocardial portions can extend. So outflow tract VTs can be anywhere, so can be pulmonary, aortic, or from both tricuspid and mitral annuli. So this is the fluoroscopic orientation how we can ablate. And especially coming to the left side, aortomitral continuity is one fibrous structure. So this is one area where you don't get accessory pathways. However, as I said, there will be epicardial side myocyte extensions where we know typical aortomitral continuity ectopic activity. So especially the left ventricle, which is less trabeculated than the ventricle, we have some false tendon sometimes, and the fascicles of the left bundle, which can give rise to arrhythmias, especially fascicular tachycardias or ectopic activities. So papillary muscles are integral part of the mitral valve apparatus. The anatomy can vary from single, multiple, and to staggered activity, where the tips of the papillary muscles can have conduction system fibers, and we even know that papillary muscle origin of ventricular arrhythmias. So these are the fascicles, and where there can be conduction system arrhythmias consisting of maybe isolated focal Purkinje cell origin or interfascicular reentries, where you can really classically demonstrate these potentials during ablation, and that can be easily ablatable electrophysiologically after mapping. finally, the venous system is very important. So both for lead placements for CRTDs and great cardiac vein, or sometimes especially left ventricular summit ablations, especially summit PVCs, sometimes can be ablatable through the great cardiac vein approach, and especially Marshall ligament, vein of Marshall can be patent sometimes, which can give rise to atrial arrhythmias and atrial fibrillation. And this is very important. Coronary sinus, as we all know, for any basic electrophysiological study, as well as sometimes even for ablation, even from the and lead placement starting from middle cardiac vein to posterolateral cardiac vein. And these are the variations, especially persistent LSVC, very important while inserting cardiac implantable devices. And this is one of my autopsy specimen. So with large azygos vein, sometimes rarely we use for to increase, to lower the thresholds of especially ICD, we keep extra lead there to reduce the thresholds. So this is ganglionic plexi, which play a role in arrhythmias, especially atrial fibrillation. So while doing atrial fibrillation ablation, so there is a lot of research on ganglionic plexi ablation as well. So especially total 5 important ganglionic plexi. So right side 2 and left side 3. So which play a role in autonomic dysregulation leading to atrial fibrillation. So thank you very much.
Guru Prasad, a very broad sweep of the anatomy and excellent areas you covered. I think there's a lot of, I think the Dr. Jaishankar discussion at the end of the
we'll
session.
have at the end, sir. We'll finish all the talks and then have the discussion, sir.
Okay, so let's hear Velu now on a difficult subject.
And associated disorders. So briefly, I will touch upon a nice opportunity. So I thank organizers of TNEPIC 2021 for giving me this nice opportunity. Today, I'll be talking on ion channelopathies and its associated disorders. So briefly, I will touch upon the basics of cardiac action potential. As we know that in non-pacemaker cell, that is in the working myocardium, the depolarization phase is due to rapid sodium influx, whereas the transient dip after the rapid depolarization is due to the transient outward current efflux of potassium channel, and the plateau phase is due to prolonged calcium influx phase, and it is followed by potassium efflux resulting in depolarization phase. So the upstroke and downstrokes are very well characterized by sodium influx and potassium influx respectively. Whereas if you take the conduction system, if for example, if you take the SA node, we have the rapid influx of calcium channel resulting in depolarization, whereas the potassium influx will result in repolarization. So this is called the diastolic depolarization of the pre-potential phase, and it is due to slow influx of sodium channel as well as due to the funny current activation. So this is a very characteristic representation of the cardiac channel, especially the NAV 1.5 coded by SCN5A gene. So if you see, this is the unfolded structure of the sodium channel, whereas when it folds by activation, it forms structure like this, whereas the S4 is porous to sodium entry. When sodium influx happens, cell membrane depolarization resulting in the depolarization of the cardiac membrane occurs. This is the characteristic distribution of the sodium channel NAV 1.5 inside the heart, predominantly presented in the upper chambers, that is the atrium, followed by the septum and along the conduction system of the heart. So it is the loss of function mutation, as well as in some of the patients, it is the gain of function mutation that is going to result in channelopathies. Loss of function mutation results in slowing of conduction, which results in re-entry mechanism related arrhythmias, the characteristic feature being the Brugada syndrome. Whereas in long QT syndrome, especially the QT3, it is a gain of function mutation which results in early after depolarization and arrhythmias. Here, if there is a loss of function mutation, then there is reduced sodium influx, resulting in reduced upstroke velocity, resulting in conduction blocks and re-entry. Whereas gain of function mutation, there is increased sodium re-entry, and which results in prolonged action potential duration, resulting in electrical as well as mechanical dysfunction. Right. So sodium channel not only results in disorders because of direct ionic function, because of indirect ionic function due to calcium channel handling, also it can produce disorders and arrhythmias, and it can produce disorders like atrial fibrillation, it can dilated cardiomyopathy and conduction system block, as well as by non-ionic function mechanisms as well. So in a nutshell, sodium channel defects can result in Brugada syndrome, long QT3 syndrome, progressive conduction system disease, atrial fibrillation, ARVC or ARVD, dilated cardiomyopathy, mixed phenotypes like sodium channel overlap syndromes as well. So this is a characteristic Brugada syndrome in which patients will have characteristic arrhythmia-related symptoms, family history may be there, and patient have documented ventricular arrhythmias or sudden cardiac death may be there with a characteristic ECG pattern, and the arrhythmias may be inducible by programmed electric stimulation at EP lab. So we have to differentiate basically between Brugada syndrome and Brugada phenocopy, and this characteristic ECG abnormality can be present in some other conditions as well, like hyperkalemia, metabolic acidosis, or myocardial ischemia as well. So we have to differentiate. Classically, the leads are placed at higher intercostal spaces, and sodium channel blocker, like in the form of flecainide or adrenaline provocation, is given, which brings out the classical type 1 ECG patterns in patients with type 2 or type 3, or in patients with vague ECG patterns. So basically, in patients with Brugada, the epicardial to endocardial phase 2 re-entry, sodium re-entry, the problem is accentuated. That is, there is a gradient generated between the epicardium and the endocardium. That is, in the endocardium, the sodium channel function is normal, whereas in the epicardium, the sodium channel mutation, the loss of function mutation is there, thereby resulting in characteristic ECG abnormality and re-entry related arrhythmias as well. And we know that there are a lot of high risk factors for arrhythmic events in Brugada syndrome, and these are the various risk factors. So due to shortage of time, I'm going to skip. So the management of Brugada syndrome is that we have to avoid or aggressively treat the triggering factors. The most important triggering factor is the hypyrexia. And during VT-VF storm, isoprenaline has to be given, and chronic therapy, oral quinidine may become handy. But in patients with high risk, especially survivors of sudden cardiac arrest or documented arrhythmias, ICDs has to be given. And sodium channel blockers, amiodarone, have to be avoided. And we have to avoid certain other drugs, certain other conditions, and we have to be very careful during perioperative anesthesia as well. So these are the summaries. Coming on to potassium channels in the heart. These are the various types of voltage-gated potassium channel, as well as we have ligate-gated potassium channel, which are very, very crucial for maintaining the membrane integrity and for various electrical functions of the heart. And we know that potassium channels are very, very important because clinically the most important and common types of long QT syndromes like long QT1 and long QT2 are due to abnormalities of the potassium channel. KCNQ1 is due to LQT1 syndrome mutation. It is due to slow potassium channel defect, and LQT2 is due to rapid potassium channel rectifier current, and it is coded by KCNH2 gene, right? And to say more than 450 milliseconds in a male and more than 460 milliseconds in a female, we define long QT syndrome. For 99% sensitivity, we take 470 and 480 milliseconds respectively. And these are the various types of syndromes like Romanov-Watt syndrome and this is JLNS syndrome and Timothy syndromes. There are various types of syndromes which can involve the multi-organs as well, not only the cardiac system, as well as it can also involve multiple syndrome. This is the long QT tree, and we know that here mutations in the calcium channel, sodium channel, as well as potassium channel can result in long QT syndrome, but the most common mutation being the potassium channel mutation. And this is Anderson-Tavil syndrome, where it is an autosomal dominant mutation characterized by potassium channel mutation, and it classically involves a triad of cardiac arrhythmias, muscle weakness, dysmorphism. Patients will have frequent VPCs, QT interval prolongation, especially QU interval prolongation, prominent UAs as well. Patient can have bidirectional VT or polymorphic VT or VF as well. So coming on to long QT, the long QT one, the ECG morphology is very classical. It is a broad-based T wave resulting in long QT, whereas in long QT it is a notch T wave, whereas here the long isoelectric followed by a T wave. It's a bed and the pillow sign which has been described, and all these three patterns can result in torsades de pointis or polymorphic VT degenerating into VF. Here long QT and long QT1 and 2 are very common. Long QT3 is less common, but it is very difficult to manage because it can happen in rest. It can occur even in a patient with low heart rates as well. So this is the Schwartz score. So if a Schwartz score is more than or equal to 3.5, then it is very high risk. And again, this is the pyramid demonstrating the risk stratification: low risk, intermediate risk, high risk, and extremely high risk. Patient with intermediate to extremely high risk have to be very aggressively pursued, and they have to be given appropriate therapy. So initial form of therapy is in the form of beta blockers to the maximum tolerated dose. If patients do not tolerate or breakthrough events occurs, then sympathetic chain denervation has to be pursued. And even though after this also, if patient is going to have breakthrough events, then patient has to be considered for ICD, and very high risk patients have to be considered for ICD straight away. So potassium channel mutation can also result in rarer forms of Brugada syndrome, as well as it can also result in rarer forms of short QT syndromes, and it can result in early repolarization syndrome, especially type 1 and type 5. And early repolarization syndrome can be in the form of J point elevation, or there can be notching, or there can be slurring as well. So coming on to calcium channel again, they are very important in patients because they can result in a myriad of syndromes, arrhythmias as well. The most common being, or the clinically very important being, CPVT syndromes and long QT syndromes, as well as short QT syndromes have also been described. Early repolarization syndromes can also occur with calcium channel mutation as well. But very rare forms of Brugada syndromes can also happen. So we can see this is the L-type cardiac calcium channel. This is very important because loss of function mutation can result in Brugada syndrome, early repolarization syndrome, and SQT syndromes. Whereas gain of function mutation of calcium channel can result in what is called Timothy syndrome. So these are the display of various disorders that can result secondary due to calcium channel mutations, right? So coming on here, it can also result in short QT, early repolarization as well. So the most important or the clinically relevant being CPVT, where the mortality is very high before 20 years of age, 50% mortality. It is due to ryanodine receptor mutation or CASQ2 mutation. One of the common causes of sudden cardiac death in infants and children, and this is a classical alternating bundle branch block form of VT, bidirectional VT, degenerating into polymorphic VT. The treatment for CPVT either in the form of beta blockers or beta blockers plus calcium channel blockers. Flecainide can also be tried. ICDs in high-risk patients, right? Timothy syndrome, again, as I am told, it is a gain of function mutation of the calcium channel mutation, a very, very aggressive syndrome because patients have high form of mortality, frequent arrhythmias, all those things. And you can see patient will have digital abnormalities, facial abnormalities, jaw abnormalities, teeth abnormalities, various forms of abnormalities. And very rarely they survive after 20 years of age. Beta blockers are the mainstay of therapy, and calcium channel blockers can be tried, mexiletine can be tried, but the effectiveness is, we do not know the real effectiveness of these therapies. Pacemakers can be tried to keep the heart rate higher, ICDs in high risk groups. And calcium channel mutation can result in short QT mutations. You can see the QT interval is here hardly 315 milliseconds, right? And it can also result in rarer forms of Brugada syndrome. And calcium channel mutation can also result in early repolarization syndrome as well. And we know that calcium channel can result in hyper-triggered activity because of delayed after depolarization and cytosolic calcium outlet, resulting outflow tract VTs in the form of right ventricular or left ventricular outflow tract VTs as well. And calcium, we know that calcium has got a role in patients with fascicular VT, especially in the form of calcium sensitive or verapamil sensitive Purkinje fiber mediated re-entry, and the treatment being verapamil or ablation in failed cases. So in a nutshell, so cardiac ion channel mutations can result in a variety of disorders. Both loss of function mutation and gain of function mutation are problematic, and increased risk of sudden cardiac death is a very, very important risk associated, and diagnosis sometimes may be missed, especially in children. And even today, challenges in detection, diagnosis, and treatment of cardiac arrhythmias prevail. So we have to have a high clinical suspicion, and these patients should be aggressively pursued and managed. Thank you.
Thank you, Velu. We now move on to Dr. Subramaniam, who is going to talk on a topic which is a little different from what we usually heard in EP meetings. Dr. Mutaya.
This opportunity. My topic is atypical sites of arrhythmogenesis. So frequently, ventricular arrhythmias arise from the RVOT and the LVOT and their supporting structures. But at present, certain locations still remain challenging areas of ectopic foci to target, and a cohesive understanding of the underlying complex anatomy is crucial in optimizing therapy and ablation success. For the next 15 minutes, I'll be presenting the relevant anatomy and challenges in identification ablation of these arrhythmias from these atypical sites. We'll be looking at sites in the pulmonary cusps, epicardial connections from the pulmonary veins, posterior superior process of the left ventricle, and arrhythmias that originate from the Purkinje fibers. We'll start with this case, a 35-year-old female who had a high PVC burden, did develop a tachycardiomyopathy, and had a recent heart failure hospitalization. This was the morphology. She had a single morphology of PVCs. This was the morphology with the left bundle branch clot pattern. A transition in around V3 or V4 leads the 2, 3, and AVF were positive, suggestive of maybe a site in the RVOT, possibly the RVOT septum. But initial mapping in the RVOT and RVOT septum did not really reveal any early activation. So this is a 3D activation mapping from the same patient of the pulmonary artery with the cusps, with the relationship of the cusps in RAO and LAO view. And you can see the earliest site of activation was in the left pulmonary cusp. And you can see the picture on the right showing the electrocardiogram with the intercardiac signals. You can see in sinus rhythm, you can see that the prepotential it comes after the ventricular activation, and there's a reversal during the PVC with the discrete isolated prepotential and maybe an isoelectric segment which precedes the QRS by 63 milliseconds. So there are the histopathological studies have shown that ventricular myocardium may extend into the aorta and the pulmonary artery beyond the semilunar valves. And these myocardial sleeves can give rise to automaticity and triggered activity. This is a fluoro showing this reverse U pattern that is used to map and ablate in this area, especially in this patient. A combination of autopsy series have found that roughly 70% of patients have these myocardial extensions. And here we can see an overlying image of that fluoroscopy as well as these myocardial extensions that may give rise to these foci of arrhythmias. So there is a few more points to understand regarding these myocardial sleeves. So similar to conduction in for example, a axillary pathway, these arrhythmias from the pulmonary artery can either be ablated by targeting their origin in the PA or the insertion into the RVOT. However, the proximal portion of these myocardial extensions and its attachment with the RV myocardium can be wide and bifurcated. And these has multiple breakout sites within these myocardial sleeves. And because there may be conduction block or other properties in these myocardial extensions, sometimes you can have a change in activation in the QRS morphology compared to these two different sites. So the most successful ablation sites are usually the distal and narrow portions that occur in the origin in the pulmonary arteries. And you can see in this picture here that you can often see discrete potentials within the pulmonary artery, such as in this patient here. And this can help guide ablation. So in our series of 8 patients that were targeted with ablation in this area, 4 of these 8 patients had a discrete potential, pre-potential. Second patient I'd like to show is a 40-year-old male with refractory palpitations. This was, again, a patient had 2 PVC morphologies at baseline. PVC1, both were left bundle branch morphology, but PVC1 was more narrow and had an earlier transition. PVC2 had a transition roughly V4. And initially, PVC2 was activation pace mapping was done in the RV posterior septum. We found a QS unipolar signal with a bipolar signal that was 20 milliseconds early, and pace mapping revealed a 10/12 pace map. So initial ablation at this area was tried, but the ablation at this site failed to suppress the PVC. So here the options were either to use a higher energy in the same area, mapping the coronary venous system, but we didn't find any early signals in the AIV area, or we can map the aortic cusp. So we went ahead with mapping the aortic cusp. And you can see when we mapped at the LCC-NCC junction, we found that there was an earlier bipolar activation for both PVC1 and PVC2 in this area. But what was the interesting finding was during pace mapping. When we paced at a lower output of 6 milliamperes, there was a 10/12 pace map for PVC1 morphology. When we paced at a medium output, QRS morphology, you can see they resembled both PVC1 and PVC2 with some fusion beats in between. But when we paced at a higher output, the QRS morphology resembled only PVC2, that is the wider PVC with the later transition. So, and the stim to QRS showed a potential decremental property when we were pacing at these higher outputs. So what does this tell us about this site? So, like I showed you in the first case, there are these myocardial extensions that originate in the outflow tract. And in this case, a PVC originating from the aortic cusp had preferential conduction to 2 exits in the outflow tract and exhibited 2 different morphologies of PVCs. Now, this has to do with the myocardial extension in these areas. And these myocardial extensions can vary in pose, location, and continuity with the underlying ventricular musculature. And the clinical way to suspect this is if you have a breakout site that is suggested by possibly a very good pace map that is remote from the VA origin site. This can potentially be explained by involvement of preferential conduction through specialized myocardial fibers. And in this case, this preferential conduction was from the aortic sinus to the RVOP. So this was hypothesized by Yamada et al. In 2007. And this preferential conduction is supported by two separate facts. One, when you pace at a higher output, you are able to selectively capture this myocardial fiber, which says that it could be a potentially an insulated structure. And also there's decrement value pace here, which possibly could be to slow conduction properties within the fiber itself. But what he hypothesized was there was a complex anatomy of these fibers, and this can often lead to variable exits within the outflow tract. So this is also regarding this anatomy of the myocardial extensions. Second, several authors have reported epicardial connections between the pulmonary veins and both atria. And these epicardial connections are important clinically because they constitute an additional difficulty for pulmonary vein isolation. And oftentimes after the vein isolation is done, we do a pace and map maneuver and try to find out if there are any gaps on the atrial side of the ablation line. But sometimes the atrial breakthrough points are not close to the ablation line, but rather far away. And when these breakthrough points are not around the line, we should suspect an epicardial structure jumping from the pulmonary vein into the atrium. So here, for example, in this publication in 2020, they are pacing from the RSPV, but the breakout site is not around the right pulmonary antrum. It is the earliest breakout site is in the right atrial septum. So this is a sign of an epicardial connection. So these epicardial connections have been described in roughly 15% of patients. They involve adjacent structures like the right atrium, vein of Marshall, and the left atrium. And roughly 40% of these epicardial connections are between the right pulmonary veins and the right atrium. You have intercaval fibers that can either connect the fibers either directly into the carina or directly into the pulmonary vein itself. And there are also connections that the septopulmonary bundle has been described as a connection of the right pulmonary vein directly with the posterior wall of the LA. So these connections need to be kept in mind when we think about difficulty in pulmonary vein isolation, especially right pulmonary vein isolation. The next case, a 45-year-old female, aborted cardiac arrest with a structurally normal heart. You can see she has narrow PVCs, rather short coupled, just at the peak of the T wave or sometimes on the ascending limb of the T wave. And this is her ECG recording. You can see this a short coupled PVC that is triggering a ventricular fibrillation and degenerating into VF. And she had a very stormy course in the hospital with multiple cardioversions, and it was refractory to all medical therapy, and she was actually taken up for ablation. So the one thing to understand in patients with idiopathic ventricular fibrillation, PVCs that trigger the arrhythmia originate from the Purkinje system in approximately 90% of cases. And these PVCs may result from abnormal automaticity, triggered activity, or potentially re-entry using the Purkinje system. So just to highlight in her, when you can see this, there's the pulmonary vein, the Purkinje fiber potentials that I will show you in the next slide, and how we hypothesize the potential re-entry within the Purkinje fiber system that was sustaining the ventricular fibrillation in her. And you can see the same patient in sinus rhythm. You see the sinus mapping, as well as these potentials on the posterior part of the septum. And just to zoom this in, so you have Purkinje potentials that precede the PVC, but more important to that, you're almost seeing a pre-Purkinje potential that even precedes the PVC. And these potentials are somewhat consistently there with the PVC. So these arrhythmias, they did arise from the Purkinje fibers. So the next question is, what causes these Purkinje fibers to be so arrhythmogenic? And in patients with structural heart disease, there is a lot of evidence that ionic current remodeling occurs. And Purkinje fibers surviving after myocardial infarction, there is a reduction in the calcium in the L-type and T-type calcium channels. Also, there is a reduction in a variety of potassium currents, which can delay repolarization and potentially harbor re-entry substrate as well. There is evidence that you have micro calcium transient releases, as shown here, and these are what sort of propagate spontaneous action potentials and give rise to DADs and EADs as well. So Purkinje fibers have been well described as drivers of ventricular fibrillation, and there's abnormal automaticity and triggered activity, as we just showed with the EADs and DADs that are common in the Purkinje cells. And what we see here is a patient with in sinus rhythm. The second beat is a white PVC, possibly from the RV. And there's actually a concealed Purkinje potential that shows up here. And subsequent to this, you are seeing Purkinje potentials that precede the PVCs with a slightly altered coupling interval. So these Purkinje potentials are important targets when we try to do ablation in these patients. The next patient, a 45-year-old male, drug refractory palpitations. You can see these PVCs have a left bundle morphology, a transition maybe V3 or V4. Lead 2, there's a monophasic R in lead 1, and lead 2 and 3 are positive. So the localization of this PVC may be a septal exit, possibly in a parahesian location. But I'd like to show you this. This is the mapping of this patient. And you can see the fluoroscopy here with the His catheter that is shown here. And this PVC was ablated somewhat very close to this slow pathway area. And I'll show you the 3D mapping picture here as well, where you can see the ablation site that is very close to the slightly posterior and inferior to the His bundle region, very close to the slow pathway region. So this is where we come into the anatomy of this posterior superior process of the left ventricle. And this area is a very important area. And if you can see here in these two pictures here, they've somewhat removed a part of the right atrium to show this region more clearly. And you can see the inferior wall of the right atrium lies above and lateral to the posterior superior process of the left ventricle, medial to the insertion of the septal leaflet of the tricuspid valve. And if you'd like to see this sort of altitudinal cut here, you can see the superior part of this posterior superior process is close to the NCC, as well as this part of the right atrium. So this has been described as a pyramidal space, and it's also been described as potential areas for the septal artery and AV nodal artery. So there is a potential for CHB when you do ablate in this area. So this is an important area to look at, and the right atrium is a good way to reach this spot, and this has been well described. So just the last two slides. So this was a 45-year-old teacher who had come with refractory, had been treated with the DC version for VT, came with with a high PVC burden. This was his clinical morphology of PVC, with V1 to V6 being positive, 2, 3 AFBF being positive. But here the clue was not in the ECG; it was in his physical examination, where you can see large, broad and soft tissue swellings, some large protrusion of the mandible. And we clinically suspected acromegaly in him. This was diagnosed both with the MRI and with a higher IGF-1 value. Patient underwent a transsphenoidal surgical resection of the pituitary adenoma. And subsequent to that, when we were tracking both, there was a serial decrease in the IGF-1 value and the PVC burden. And he's not had any ventricular arrhythmias. Now it's almost been 2 years following this surgery. So this is just to give you a glimpse of the different kinds of atypical sites of arrhythmogenesis within the heart. And thank you for this opportunity.
Yeah, thank you, Dr. Muthaiya. I think we'll move on to the next talk by Dr. Joseph.
For this deliberation is early repolarization syndrome. I'll go directly into the topic. Here in this next 10 to 15 minutes, the epidemiology with it, the newer pathophysiology and pathology associated with it, and also briefly look at the therapeutic options associated with early repolarization syndrome. So, early repolarization syndrome has been known from time immemorial, and the definitions has been changing from the time when Osborne described the waves, J waves. So the mandatory ST elevation with concavity upwards has been dropped now, and the newer definition just involves distal QRS slurring or a J point elevation of more than 1 millimeter in the STT junction. So ST elevation is not mandatory to define an ERP these days. So, but the Anselwitz classification of ERP still holds good, where type 1 corresponds to the ERP pattern in lateral leads, type 2 inferior and infralateral leads, and type 3 for the inferior lateral and right pericardial leads. So the definition for ERS will be, early repolarization syndrome would be, a patient with an ERP pattern in the ECG who has been resuscitated from otherwise unexplained ventricular fibrillation or a polymorphic ventricular tachycardia will be qualified as an ERS, early repolarization syndrome. Or a patient with ERP pattern on an ECG with an autopsy negative sudden cardiac death will also be classified as an early repolarization syndrome. It has always been known that early repolarization pattern is always benign, but in 2008 there has been case reports even before 2008 that it has been associated with sudden cardiac death and with some arrhythmias. But it was in 2008 Azagar did a case control study which showed that it is not truly a benign condition. There has been reports, case controlled reports of people having sudden cardiac death with ERP. And this is one of our patients where you could see that the ERP is present in all the leads, in the infralateral leads and also in the right precordial leads. And there's a VPC which is coming from posterior papillary region area, and post VPCs there has been exaggeration of the J wave response, and followed by which there's a polymorphic VT. So Usually this benign entity of ERP is no more true, and it has been associated either a VPC trigger or an ischemia trigger can be associated with increased risk of VTVF in these patients. And phase 2 re-entry, which we'll see a little later, will be the cause for this VF in these patients. So going into the epidemiology, the prevalence is varied because of varied definitions and interpretation used in different studies. So they qualify from 1 to 13%, but the recent studies using the new definition has said that it is going to be around 5%. And there has been a male preponderance with more than 75% of ERP patients being men. This is because of high ITO density channels present in the epicardium, which we'll again see later. And this ER pattern is most commonly found in younger physically active individuals. There is some racial predilection, like blacks and South Asians more than Caucasians. And this ER pattern regresses with aging, varies with heart rate, diurnal variations is also present because of the biophysical properties of the channels, ITO channels. And that hallmark study, that is the Isager study, which showed that 31% of patients with idiopathic ventricular fibrillation have this kind of ERP pattern. But the recent studies have negated that this percentage may not be so high, okay, and it might be around 5%. And coming to the pathophysiology, we all know that the phase 1 phase 1 of the action potential corresponds to the QRS-ST junction of that is the J point of any surface ECG. So it is usually this phase 1 which alterations which causes this distal QRS slurring or the J wave, which has been used in the ERP definition. So here what really happens is this ITO channels which are present, the potassium, the calciums are the main ionic outflux, which is causing this early repolarization pattern. So and this is mainly predominant. This is mainly happening due to the outward ITO channels, potassium channels, which are present in the myocardium. So what is the difference between a normal and an ER patient would be this phase 1 action potential when it happens in an epicardium and endocardium. There is a difference. This difference is attributed due to the increased ITO density in the epicardium, which leads to outflux of potassium very early. This leads to a shortened action potential. This shortened action potential happens mainly in the epicardium, and this leads to a transmuted dispersion of electrical gradient, and this can lead to a phase 2 re-entry, which can happen and can be triggered in ER patients. So this is a normal response which has been exaggerated in a ERP patient during phase 1, and this indeed leads to an electrical gradient and leads to a phase 2 re-entry related arrhythmias. So this is the same thing which has been reported even in Brugada syndrome, but there it is more on the RVOT region, this kind of transmuted electrical gradient. And in case of ERP, it is going to be in the inferior and infralateral leads of the LV. Of the LV region. So that is the reason why both Brugada and ERP have been categorized as the J-wave syndromes. So, but recently what has happened is Ruben and colleagues have found that the areas with latest activation, those areas have shown some kind of structural alterations with fibrosis and connexin channels alterations in those inferior and infralateral walls. This might be leading to this kind of arrhythmic risk because of fragmentation of QRS. But this has not been consistently found, but there has been reports, subsequent reports from Nadamani and colleagues that this alteration might be due to exactly of some kind of fibrosis in those areas. So EKG imaging using the electrode grid can differentiate between the epicardium and the endocardium activation. Here you could see that when you pace from the atrium or from the ventricle, the activation is happening the last at the RV inferior or the inferior regions of the ventricle, and this is the area where these late potentials are seen, and these are the areas which will contribute to the J waves or the distal QRS layering seen in the ECGs. So I have tried to correlate all these ECG findings to identify the malignant to differentiate the benign from the malignant ERP pattern. So E categorized the type 1, type 2, and type 3 will fall into a malignant ERP, and there has been a when there is a greater amplitude of J waves or distal QRS slurring, or an horizontal or downsloping ST segment which could be seen immediately after these J waves, or ERP associated with increased long QT syndrome. All these things can attribute to the risk. And if there is exaggeration of J wave post PVC, can also, as seen in our surface EG, can also lead to this kind of J wave syndromes. Can also contribute to the malignant arrhythmic risk of ERPs. And smaller TVS was also associated with malignant ERP risk stratification. But this is not foolproof, because many of these times there are the association of ERP in the general population is quite high, but this only ECG findings are not able to find out risk stratify them exactly according to the ECG criteria. And genetics, there are half a dozen genes which have been identified with ERS, but all those genes are all those genes are contributing to this potassium and the calcium outflux in the phase 1 and the phase 2. So none of these genes have been associated with symptoms of has been found to be a significant point mutation or a significant variant of concern in any of these, because of phenotypic heterogeneity which is present. And this genetic study, carrying out genetic study, adds very little to the diagnosis, prognosis, and therapeutic management in all of these patients. So there has been a concern about how to risk stratify these patients. It is not well defined, and the recognition of truly malignant forms is quite difficult. Electrophysiology testing does not really appear useful for the stratification. Most of the time, it is VF is infrequently induced and has no predictive value for ICD therapy. Bastian et al. Found out that ajmalin, which has been used like flecainide provocative challenge test, has not been consistent in all studies. 1/3 had an exaggerated response, 1/3 did not have any kind of response with ajmalin. So ajmalin does not really contribute to any of to risk stratify these patients. So management, as we all know, ICD stands the cornerstone here. Patients with about a sudden death in the absence of identifiable cause in idiopathic VF are treated with ICD, and symptomatic family members with a history of sudden cardiac death gets a class 2A indication for an ICD. The drugs, no sodium channel blockers can be effective in this kind of patients, but quinidine, along with the sodium channel blockers, it also has an ITO inhibitor properties, so it can normalize ECG, decrease VF induction, and also been used effectively in VT storm. And isocanal infusion increases the calcium current during the phase 2, and this can neutralize the transmural gradient and is helpful in emergency treatment of arrhythmic storms. And there has been case reports of phosphodiesterase 3 inhibitors, again because of increasing the calcium influx, which can help in these kind of scenarios. So the management mainly rests on ICDs and drugs. And when there is a triggering point like VPCs or an ischemia in a patient with ERP, try to be very cautious, try to treat them aggressively. And sometimes a culprit VPC can be targeted to avoid any arrhythmic risk. And Nadamani et al. Showed that epicardial ablation of late potentials has been used to normalize ECG pattern in these patients, and has been known to alleviate the arrhythmic risk. But the procedure has not been validated and it cannot be used in all patients. So it still is at the scientific research level alone. So I will leave you with the images of Danish player Eriksson, who suddenly collapsed in the field, was taken to the hospital, and at last there was no real clear diagnosis. A suspicious diagnosis of ERP was made, and he has been implanted on ICD. So the same holds good for almost all, even in our population, because identification of patients with early reposition pattern at risk of arrhythmia is always challenging. This transmural gradient is the most accepted postulated mechanism. EKG imaging or monophasic action potential electrodes, which can be used to record individual action potential from epicardium, endocardium, can hold promise in the future for risk stratification of these patients. ICD, quinine, and isoflurane are the treatment options at present available. Just like Brugada syndrome, structural alterations may outweigh the electrical theory in the coming days with high definition MRI, EKG, and monophasic action potential electrode mapping. So I will leave it at this point. Thanks. If there is any questions, I'll be happy to answer. Thank you.
Thank you. Sir, please.
Yeah, I think Dr. Nambudiri was caught up in travel. We got his message. So I don't know if he's there in person, but we can start with his important talk.
Plays an important role in pathogenesis of many cardiac arrhythmias. In addition, cardiac disease leads to neural remodeling and sympathovagal imbalances with its own arrhythmogenic effects. Neuromodulation in atrial fibrillation, an important field of arrhythmia management in refractory ventricular arrhythmias and atrial fibrillation, has shown promising clinical results, particularly in patients with inherited primary arrhythmia syndromes and structural heart disease. In the next 15 minutes, I will be discussing the basics of cardiac autonomous nervous system, modes of neural modulation, a few clinical scenarios with the available neuromodulation options in them, and the evidence to support its use, evolving areas under research in this field, and some knowledge gaps. We know cardiac autonomous nervous system can be divided into extrinsic, that involves the central nervous system outflow from brain and spinal cord, and then the extrinsic intrathoracic ganglia, that is outside the heart but within the thorax. They involve dorsal root ganglia, stellate ganglia, and the sympathetic chain, and then the intrinsic cardiac autonomic nervous system. The intrinsic cardiac autonomous system, or CANS, is comprised of an extensive epicardial neural network of nerve axons, interconnecting neurons, and clusters of autonomic ganglia known as ganglionic plexi. From a physiological point of view, the ganglionic plexi serve as the communication centers between the intrinsic and the extrinsic CANS, and complex interaction can happen between these different sites of cardiac autonomic nervous system, along with the baroreceptors and renin-angiotensin-aldosterone axis. In the intrinsic cardiac autonomic nervous system, basically there are two components: parasympathetic pathways and sympathetic trunks. Parasympathetic are concentrated in ganglia in various fat pads, especially around the posterior to atria or at the venous entry into the atria. Sympathetic trunks along the coronary arteries, and then transmurally penetrate to innervate the rest of myocardium. One thing at this point in time we should remember is parasympathetic stimulation in atria is for profibrillatory, while generally parasympathetic innervation is considered as antifibrillatory in the generally protective across other organs and antifibrillatory in the ventricles. Along with that, the dysregulation related to other cardiac pathologies like regional interruption of vagal and sympathetic innervation in areas of fibrosis after myocardial infarction, denervation supersensitivity, changing the electrophysiologic milieu, and also nerve sprouting following injury, such as infarction, leading to heterogeneous sympathetic innervation. And all these things can lead on to potentially lethal arrhythmias. Autonomic modulation had been successfully used in heart failure and arrhythmia for a long time. There are certain characteristic features common to brain and heart in terms of autonomic modulation. A fascinating property of autonomic modulation is that autonomic effects exhibit memory, whereby short durations of therapy results in long-lasting effects. Similarly, recent evidence suggests that synaptic plasticity, the ability of neurons to alter the strength of communication at synapses, which in turn results in long-term potentiation or depression, occurs not only in brain but also in cardiac GPs, like ganglion plexi. It acts at multiple levels of neuraxial system. Brainstem and higher centers, there are ways to stimulate electrically vagal stimulation. This has been found useful. It can be a selective afferent stimulation as an auricular branch of vagus stimulation through tragal stimulation. Low-level stimulation of the vagal nerve also works by increasing the vagotonia. Thoracic T1, T4 spinal cord intervention can be done with the thoracic epidural anesthesia and spinal cord stimulation. Thoracic sympathetic chain and ganglia T1 to 4, T4 can be blocked with stellate ganglion radiofrequency ablation, cardiac sympathetic innervation if you want to take care of everything. Intrinsic cardiac nervous system, ganglioneplexy ablation in the epicardial pad of fat, and botulinum toxin injection also has been found to be useful. And remotely renal artery innervation is also another mode of approaching neural modulation. There are established entities as well, like sedation, general anesthesia, beta blockade, stellate ganglion block, cardiac sympathetic innervation. All these things are very well known to modulate the response to arrhythmia and can be useful in the treatment of arrhythmia. And these are evolving areas on the other hand. Let us see some scenario. Like acute management of electrical storm. If the patient comes with a VT storm, multiple shocks, is there a role for neuromodulation? Sedation, GA, beta blockers are well-known strategies. Stellate ganglion blockade and thoracic epidural anesthesia are extremely useful in this condition. Studies have shown that sedation, GA, beta blockade, all are highly useful in this setting. When you combine with the amiodarone, the recent evidence suggests that propranolol is probably better than metoprolol. This also could be due to some change in the electrophysiological milieu in patients with heart failure or patients with electrical storm. The selective downregulation of beta-1 adrenergic receptors over beta-2 receptors in heart failure, as well as propranolol sodium channel blockade and central nervous system effects, are the mechanism probably proposed for the superiority of propranolol over metoprolol. That is also linked to neural modulation. The stellate ganglion can be blocked percutaneously with the pivacin or lignocaine. Pulsed RF can be used to block the stellate ganglion. And all these things decreases the sympathetically driven cardiac excitability by reducing both efferent sympathetic signals to and efferent signals from the heart. Thoracic epidural anesthesia, on the contrary, helps to block either side of the sympathetic chain. Percutaneous injection of local anesthetic into epidural space at T1 to T5 spinal cord. Stellate ganglion block and thoracic epidural anesthesia are extremely useful, and we have sufficient evidence. In the systematic review of 38 patients with electrical storm who underwent stellate ganglion block, ventricular arrhythmias were significantly reduced in 92% of the subjects. Similarly, 6 out of patients, thoracic epidural anesthesia was useful in control of more than 80% of the ventricular arrhythmias. In inherited primary arrhythmia syndrome, we have long record of utility of stellate ganglion block and also cardiac sympathetic innervation. Long QT syndrome has been a prototype for this. Apart from pacing, add-on drugs and ICD, beta blockers and cardiac sympathetic innervation are extremely useful in neurohormonal modulation. This has been pioneered more than 50 years now with multiple studies showing the benefit of cardiac sympathetic denervation in patients with an QT syndrome. It is again a lower half of the stellate ganglion and T2 to T4. Left cardiac sympathetic denervation is performed as the initial option in this case. It significantly reduces both efferent sympathetic and efferent neurotransmission to and from the heart, respectively. The largest trial of cardiac sympathetic denervation involved 147 patients. And this has shown that during an 8-year follow-up after undergoing cardiac sympathetic denervation, cardiac events in these patients decreased by more than 91%. And those with electrical stroke who had experienced multiple ICD shocks to begin with had a median number of ICD shocks decreased by 95%. Now, cardiac sympathetic denervation is a class 2 indication level of evidence say, in patients with a refractory SIGO or ICD shocks despite beta blocker therapy. We have some experience in certain selected subgroup of LCSD, JLM syndrome, 6 patients, 5 males, mean age 39 months, all had sensory neurotoughness. Mean QTC duration was 600 milliseconds. T-wave alternance, everyone had. 4 children had SIGO, 1 had VT. After cardiac sympathetic denervation, you can see significant reduction in QTC, and though it remained above 500 milliseconds throughout. So cardiac sympathetic denervation who had undergone this procedure, no events were noted over a follow-up period of 24 months. So significant QTC reduction was also noted in them. In CPVT, neuromodulation has got an equal or more relevant role. Patients with a structural heart disease like ARVD, if they come up with a VT stop, is there a role for neurohormonal modulation? The current evidence suggests that bilateral cardiac sympathetic denervation is more useful than left cardiac sympathetic denervation alone. And this has been observed in the initial phase itself, when left cardiac sympathetic denervation for refractory VT in patients with a structural heart disease showed that only 5 out of 9 patients benefited from the procedure, while more than 75% of the patients had reduction in their ventricular arrhythmia burden with a thoracic epidural anesthesia, which gives a bilateral block at the same time. So bilateral cardiac sympathetic may be more effective than left cardiac sympathetic alone. There is also a differential innervation of the ventricles. Right stellate ganglion supplies the anterior part of the ventricle, left posterior part of the ventricle. And even when the RV in ARVD, there is an abnormal sympathetic innervation. So there could be a role for bilateral cardiac sympathetic denervation over and above LCSD by these features itself, but there are some conflicting evidence, and more research is required in this area. A retrospective analysis had clearly shown that BCSD is more effective for treatment in structural heart disease than LCSD alone, and all this evidence should favor BCSD in patients with a structural heart disease. Atrial arrhythmias, is there a role for autonomic modulation? Of course, even when we do pulmonary vein isolation, we are ablating inadvertently some sites of ganglioneplexy. Vagal signaling to the heart is relayed through this ganglioneplexy, and we know high-level vagal stimulation can initiate atrial fibrillation in patients. And a randomized study had clearly shown that botulinum toxin injection to epicardial pad of fat can reduce the recurrence of atrial fibrillation in these patients. And we have already mentioned these common additional modalities: cardiac sympathetic denervation, renal denervation, ganglioneplexy ablation, ganglioneplexus modulation, low-level vagal or tragus stimulation, low-level carotid stimulation or vagal stimulation, spinal cord stimulation. All these things are in the evolving stage. There are some specific questions that still require experimental investigation. What is the exact mechanism of benefit? Though it is obviously it should be based on sympathoanalysis, but something more beyond that we should know. Do patients have differing baseline autonomic states that require individualized therapies toward the optimal sympathovagal balance? That is not clear. And how can one effectively titrate the neuromodulatory therapy? Is there any way to identify biomarker, etc.? Something like X100A, H100B, something of the neuromodulator biomarkers can be used or not. So concluding, ladies and gentlemen, neural modulation in cardiac arrhythmias primarily focus on reducing sympathetic hyperactivity or enhancing the vagal activity. Left cardiac sympathetic denervation continues to improve the outcomes for those with non-QT and CPVT. And in patients with refractive VT or VF, especially in patients with a structural heart disease, bilateral cardiac sympathetic denervation is more preferred now over left cardiac sympathetic denervation alone. Small clinical studies have shown multiple levels of modulation of neural activation system can help in reducing ventricular arrhythmias in AFib, and they are in the evolving stage. And case selection for likely responders is limited by the current knowledge gaps in understanding of the cardiac autonomic system. Thank you all for your patient hearing.
Thank you for all the speak. I think I have for discussion 18 minutes. As I have a question for Guru Prasad. Two things in regards to anatomy, the accessory pathway knowledge. Now we talk about posteroseptal pathways, and these were all, as I believe, a surgeon's view of the pathways, and fellows tend to get confused when you talk of, but as I understand, when we talk of the septum, we talk of the atrioventricular septum, and the posteroseptal, what we call, is near the mouth of the coronary sinus. We call it posteroseptal. Now the coronary sinus is right behind the heart, not close to any septum. So should we abandon this thing of calling these coronary sinus, pericoronary sinus pathways as septal? Because what septum lies near the coronary sinus? None. What is your, so should we call these, if at all, to not create too much confusion, as paraseptal pathways? Because they are not septal pathways according to me. What is your opinion on that? And my second question, people are using the term apical crux, which is an oxymoron according to me. And people still use this. I think the term apical crux should be abandoned because there is no crux near the apex. What is your opinion on these two things?
Guru, you're
You
muted.
have to unmute. You have to unmute.
Yes, sir. Yes, sir. Yes, sir. I am a little one in, at least, when I was with Professor Datta, the great anatomist of India, at least I would have dissected at least more than 50 cardiac specimens. I have very much interest in cardiac anatomy, especially when I was in Mayo observing Dr. Sam and all, who have, autopsied and then studied almost thousands of heart specimens, at least nearing 100. Whenever I visit my friends, I collect the specimens in forensic department. I go to anatomy department. At least more than 50 cardiac dissections I did. See, everyone knows, in a good electrophysiologist, the true septum of the heart is very, very small area, maybe 25 pi's coin. The exact fossa ovalis and surrounding little musculature is only true anatomic septum. And the true septal structures are fossa ovalis and lower anterior septum penetrating his bundle, and mid septum is the AV bundle. These are the clear anatomic sites. So the true septum is very, very small area, actually. Like what you said, definitely coronary sinus is posterior. And as you know, it actually, it is little away from the true septum. You are right, sir. Maybe what we call it as perinodal approaches, maybe, not nodal, pericoronary sinus approaches. Especially, I was very much interested in mapping the coronary sinus os with lasso. small lasso I used to take, and then I used to map, because I did this experiment in St. Jude Arrhythmia Academy in Tokyo. There was a beautiful workshop. 2 weeks I spent in ablation, hands-on, everything. So I studied lasso, put the small lasso around coronary sensor.
Guru Prasad, if I may interrupt, I think we have several discussions, so I think I'd request you to stick to the point. Stick to the point.
You can definitely, we can better avoid these, like oxymorons, you said crux and all, because even I'm not sure this crux and then summit. I think let us stick on to the textbook description as soon as the anatomy is concerned as of now. So like what you said, whether we call it as peri-sinus fiber approaches, maybe when we make our own mark, we can name whatever it is. That is the conclusion.
Okay. Are there any other questions for the anatomy section? Any questions from any of the panelists or speakers or Dr. Jaishankar?
Just this Hans Christensen, who had a sudden death, aborted sudden cardiac arrest, and Dr. Joseph left it midway that, perhaps it's one of those inherited arrhythmogenic disorders. I mean, despite extensive investigation, nothing could really come out. What is your viewpoint, sir? What is the likely possibility?
Yeah, so there are several gaps in our knowledge, and I think this is a evolving field, and probably every year things are changing, and there are many which we cannot categorize. We cannot categorize into any known inherited arrhythmia syndrome. So it's just a lacuna in our understanding. For example, where did we know about ARVD? I had not seen a single case. I must have seen till I finished my DM and did my EP, and suddenly we started seeing ARVD. So I think we didn't know much about it. Now, I had a question to Velu, and to Mutaya also. The ST elevation in early repolarization syndrome, in Brugada syndrome, and benign ST elevation, benign J point elevation. Do these all reduce with isoprenaline? Because as I understand, at least the benign as well as the Brugada, as well as the ERS, as well as Brugada, the ST elevation comes down with isoprenaline. Is that correct?
Hello.
Yes, we can hear you, Velu.
Yes, sir. Sir, in Brugada syndrome, it is mainly due to the heterogeneous sodium inactivation or sodium slowing of conduction due to reduced sodium entry or phase 2 re-entry. Whereas in early repolarization, it is the augmented potassium efflux. In both these conditions, the ST segment elevation can be reduced by isoprenaline by augmenting the calcium transient currents. But I don't know about benign ER, whether I don't know what happens in benign repolarization. But in Brugada, for sure, isoprenaline reduces ST segment elevation and reduces the heterogeneity between the epicardium and the endocardial dispersion.
Dr. Mutaya, what do you feel in the benign J point elevation? Also, we give isoprenaline, does, as I understand and as I remember, it does reduce with isoprenaline. Dr. Mutaya? Or I think, yeah, we can't hear you. I think you're probably muted.
Can you hear me now, sir?
Yes, we can.
So I think theoretically, in the isoprenaline reducing the ST elevation in Brugada, I think I agree, sir. But in a benign thing, when there is no gradient between the FP and the endo, and other J-wave syndromes, I'm not sure about the role of isoprenaline in reducing these ST elevations.
Okay, no, my question was, what is the value of, so if my question was like this, if ST elevation reduces in everything with isoprenaline, in all these three, I mean, then what is the value of is there any value in an isoprenaline test as a test?
Sir, but as a risk stratification, thing, isoprene, and in a benign case, I'm not sure that there would be a role, sir, unless there would be a gradient between the endo and the epi.
Okay. Now I had another question, which is a takeoff from the Yamada paper and the breakout of the PVCs in different directions. Very often we see patients with unifocal PVCs, very frequent unifocal PVCs, who also on a Holter have multiple couplets. And you see in the couplets that often we call it a multifocal couplet because the second beat of the couplet looks quite different. So is this something similar to actually is one focus only but different breakthroughs, or is it because of ventricles being in the partial refractory period? Because some couplets look absolutely identical, and in some couplets the second beat looks different, but otherwise the rest of the PVCs are all unifocal. So what is your view on that?
These multifocal couplets, definitely is the possibility that they could be a potentially breakout through a myocardial fiber that's conducting. So these couplets, the only thing is whether the coupling interval of these couplets are the same would add some evidence regarding where these PVCs are coming from, but it's definitely a possibility. The concept of the couplet was not described in the original paper. These were all single PVCs that they were preferentially conducting, but it is a possibility. It is possible that one of these PVCs are preferentially conducting.
Okay.
So we have time. One more last thing, which is burning. Of course, we may have talk subsequently in asymptomatic Brugada. I mean, if Joseph can take the question and sir can lead it through. We all the time get these referrals, and many times we are at a loss. Risk stratification, no matter what we do, we come out with nothing. And these patients, some of them will go for pre-employment checks and then they are rejected. So I request Joseph to clarify and then sir to shed light on the topic.
Yes, sir. So, as sir was asking about isoprene also, definitely there is a study on by Ahmad which says that isoprene decreases the J waves in ERP. And coming to Jaishankar sir's questions, Brugada, there's definitely algorithm has now been established clearly, sir. So it's like when it is a fever-induced Brugada or a asymptomatic Brugada, if the patient doesn't have any of the risk factors like syncope or family history of sudden cardiac death or anything, I think most of the time it is better to watch him carefully and avoid all the precipitating drugs. But on the other hand, if it is fever-induced Brugada, or fever-induced Brugada is slightly different from Brugada induced by drugs. So fever-induced Brugada, maybe those patients might require a risk stratification. In those kind of cases, I think a flecainide challenge will also come in place. But for a drug-induced Brugada, I think it takes a little second seat where we need to watch them carefully and avoid drugs. And EP study has a very little role for risk stratification in these kind of patients.
I think probably what Dr. Jaishankar also wanted to include in the discussion, if I mistake not, is, patients come with a Brugada pattern, just ECG taken as a routine evaluation, and now what to do. I think if it's a type 3, if it's a type 2, you would not worry so much. But if the type 1 Brugada pattern spontaneous, then as you say, what you don't come up with much. You give a flecainide challenge, little bit it may increase, but nothing else happens. Genetic testing, we really don't know what is the role. ET study, it's only the Brugada brothers who found some value. And I have, out of several I did, and I have also lost interest in doing EP studies because yield is extremely low. Holters really don't help us. Sometimes you think that during sleep or bradycardia, they may show much more exaggerated pattern, but really doesn't really help us making decisions. So I think if there's a completely asymptomatic Brugada and no family history of sudden death, I would go ahead and give fitness with these caveats and basically say prompt treatment of fever. Prompt treatment of fever and avoid any drugs that cause bradycardia. That's all that I have been doing in my when I have to give fitness for such people.
And also,
as that is the current, that at this current level of understanding in 2021, maybe I'll speak differently 2-3 years later.
That's it. When for some reason these patients have a vagotonic response and we are not able to give them a beta blocker, and that also is a worry. There's one question in the chat box, sir, and I think this is for Joseph. How do we give pre-op evaluation in asymptomatic patients with ERP? I think is more or less the same what we've been discussing.
Yeah, the answer is ERP is quite common in the population. I don't think we need to attach much importance if there is no history of sudden cardiac death or syncope in those kind of patients. I don't think I will even think twice before giving a fitness for a pre-op evaluation ERP patients. We can just directly give them a fitness.
I think I'll wind up one more last comment, Guru Prasad, which I should make is that, hello, am I audible? Am I audible?
Yes, sir. Yes, sir.
Okay. So I think we have to wind up. One last comment I would make, Guru, also in the aortic, the nomenclature. You know, we keep saying aortic cusp, but cusp is actually a wrong term. We have to either say aortic leaflet or the aortic sinus. I think with that, Dr. Jaishankar, we come to the end of this very nice session. I think all speakers did more than adequate justice to their topics.
Yes, sir. Thank you, sir. Thanks for comparing and chairing this session. Thanks to all the speakers. Please do stay with us, and then I think we move on to the next symposium. Thank you very much, sir. Good day.